Welcome. It's such a pleasure to see so many former students and current students and colleagues from our law college on this call. I'm Ellen Bublick. I'm the Dan B. Dobbs Professor of Law. I'm also faculty director of the Arizona Law Phoenix program, which is providing Arizona law students with classes and externships up here in the Valley during the spring terms. In this health crisis, one thing I really miss is walking down the halls of the law college and hearing what my brilliant colleagues are working on. So I want to give a huge thank you to our Director of Development, Megan O'Leary, and our Alumni Engagement Coordinator, Karina Eklund, for creating this online space for our Wildcat community. Every Thursday at lunchtime, and I've signed up for the whole series. Today, our subject is the other front line, COVID-19, immigrant workers, and public health consequences. As you may have seen in the news, more than 40% of US coronavirus deaths have been linked to nursing homes. The likelihood of death for an infected person linked to a nursing home is 17%, more than 4 times the national rate. Arizona doesn't currently report the number of cases and deaths linked to nursing homes, but the Center for Medicare and Medicaid has begun to release some data. And in a list of COVID deaths in nursing homes by state, Arizona has the 13th highest number of deaths. Data released by Maricopa County suggested that as of June, people who live in long-term care facilities accounted for 66% of Maricopa County's coronavirus deaths. In this dangerous environment, studies show that workers in assisted living are disproportionately likely to be Latinx and African American, 2 groups that have also been disproportionately affected by the coronavirus. What can we do about the vulnerable patients and caregivers in these environments? With me to talk about this important question are Professors Tara Sklar and Shefali Milchark Desai. Professor Sklar is Professor of Health Law and Director of the Health Law and Policy Program at Arizona Law. She launched and oversees online graduate and undergraduate programs in health law, with an impressive array of programs that include courses in aging law and policy, health information policy and data security, health law for health professionals, and regulatory science. In terms of scholarship, Professor Sklar's work has appeared in the New England Journal of Medicine, the Journal of Empirical Legal Studies, and Jury Metrics, among others. Professor Milchark Desai is Assistant Clinical Professor, Director of the Workers' Rights Clinic, and co-chair of the Bacon Immigration Law and Policy Program at Arizona Law. She, along with her students, provides legal advice and representation to low-wage immigrant workers. Recently, she prevailed in a federal district court case that established new law under Arizona's minimum wage earned paid sick time law. Professor Milchark Desai teaches immigration courses in the undergraduate law, master's in legal studies, and foreign diplomat training programs. She researches and writes at the intersection of feminist and critical race jurisprudence and immigration law and employment. Her work has appeared in the Columbia Human Rights Law Review and the UCLA Women's Law Journal, among others. We are so lucky to have these 2 brilliant and engaged scholars with us today. We are also lucky to have all of you and your talents. And as you have a question for these panelists, please submit your question under the Q&A function so that at the end, we'll have time for our panelists to address them. And now let me turn over the floor to Professor Tara Sklar to tell us more about this important topic.
Great. Well, thank you so much, Ellie. I appreciate the introduction, and my thanks to Megan O'Leary for bringing us all together and coordinating this whole LawCats live series, and to all of you for joining in. I'm personally based in Washington, D.C., so I think one silver lining of this pandemic that it has brought our community together in really radically different but important ways through webinars such as this one and the whole series. So given this is the first series of what we may be doing into the future, it'd be really valuable to hear your input and how we can continue to improve these educational talks going forward. So with that, I'll go ahead and get started with my slides. So this pandemic has brought us all together. I recently heard this, I thought, very eloquent quote from Malcolm Gladwell, describing the pandemic as the epidemic of the invisible and the forgotten. And I thought that was very eloquently described what Shefali and I have been seeing with this intersection between elder care and workers' rights during the pandemic. And basically, how we treat low-wage workers in the nursing homes has a huge effect on how we can protect our older population now and going forward. The bulk of the conversation will be looking at workers' rights and what's happening in nursing homes right now. And then the other 2 points at the bottom of the slide I just want to briefly touch on is what we hear about more and more in the media is the death count. But there's a lot behind those numbers, which are also underreported numbers, including the loss of years lived and all the suffering. More and more is coming out about individuals having prolonged COVID-19 symptoms 100 days after they have the infection. And in addition to that, there's a number of people that have delayed care or not gone to the hospital because they don't have COVID-19 and they're afraid of getting it. And those types of issues are the hidden suffering that we aren't seeing. And there is a talk that we're doing as part of the health law program on July 17th with NYU Medical School, where we talk about that issue, and happy to talk more about that later on. The other point I want to mention is that all of this could have been largely preventable, and I give 2 examples of nursing homes in America and internationally where there have been no COVID-19 related deaths and what they did, and also some very important pending federal legislation where we could really look at increasing that going forward so that quality care is tied to metrics and resources going forward. So you may have heard of this term called super spreaders, which is coming up more and more in the media. And that's where it could be just a general population, people that may not know that they have the coronavirus. They could be asymptomatic, or they may not realize they're still shedding the virus after they've had symptoms. Where we're seeing it in the nursing home and long-term care facilities is that the general wages there are extremely low. And so just imagine if you miss any work at all, what that could mean for paying the rent, paying your bills. So a number of aides actually work at multiple facilities in and out of home care just to pay the bills. And they may be asymptomatic or they may have symptoms but are encouraged to work anyway, and because their job security is so precarious. So one headline that was in the news quite a bit in May was around all the nursing homes in New Jersey, and there was a particularly shocking one where a nursing home was being accused of a makeshift morgue where they hid over 17 bodies before they were discovered by the Health and Human Services workers. And in response to this, the head commissioner for the state of New Jersey, Judith Picelli, said we really want to learn from this experience. We don't want to see this happen going forward. This is horrific. This is horrible. What can we do? And one question was, well, why don't we try to limit the spread of exposure so that you don't have aides working at multiple facilities? And her response to this is this quote that I pulled directly because I thought it was so illustrative of this disconnect, where she specifically says, well, we don't want to limit people to not work at one organization because the wages are not enough. And these people need to support their families, put food on the table. They're working their little hearts to the bone trying to survive. There are many other ways that she could have responded to this question, looking at the low wages and how to incentivize individuals to not work at multiple facilities just to pay the bills. Yet even in the midst of this crisis, this was the response. And that's some of the disconnect that we need to address. And a lot of this harkens back to a vilified figure in our history, Typhoid Mary, at the turn of the century. She was also a low-wage immigrant worker who being a cook was her trade. And even though she was accused of affecting over 50 people, 3 of which died, she was always an asymptomatic carrier. So one issue that Shefali and I are currently writing an article on for the Journal of Elder Policy is taking this issue in history and where there have been significant public health communication failures along with safety net failures, where issues like this one and then those that we're seeing right now could be more proactively addressed to curb the spread of a pandemic in a way that helps people rather than criminalizes them. So in addition to the staffing issues, which I just briefly touched on in terms of how the low wages are encouraging workers to have to work in multiple facilities, there's a big issue in terms of actual infectious disease controls and outbreaks, one of which I mentioned with New Jersey. But even pre-pandemic, over 80% of nursing homes had some violation with poor infection control. There were 380,000 deaths reported by the CDC for infection control issues in nursing homes. It's a huge issue that hasn't yet been properly addressed. And then the third point there is on emergency preparedness and accountability. Just thinking about the bigger picture here, what are we going to do with individuals when they can't stay in the ICU and they need to still be recovering from COVID-19 and they're older and they were nursing home residents. So they've been being readmitted at nursing homes, but yet there, without the adequate personal protection equipment, the adequate staffing, the ability to isolate patients, we're seeing the disease spread. And so there's been a lot of confusion and misinformation, and that's part of the reason that we're seeing this continual hike in what's happening with positive cases and deaths among the elderly in nursing homes. And what's sort of horrific about what's happening is an article I recently wrote with a co-author of mine for the conversation, where more and more states are trying to ask for immunity, when more nursing homes are asking for immunity from civil liability in terms of some of these potential lawsuits that we're seeing. So if you're interested in that topic, then please reach out and read the article and what we're saying in terms of that final legal protection is still needed. So next slide, and I'm going over on my time, so I'll just kind of briefly finish up with these two examples. That there are some bright lights out there that we can look towards. The case in Baltimore, where there hasn't been a single COVID-19 related death. That CEO proactively hired an infectious disease control specialist who had protocols and training. He minimized any kind of exposure to the residents and did a number of other procedures that have safeguarded his facility. Similar lessons were learned in Hong Kong. Internationally, the exact opposite is happening in Canada and the UK. So we can also learn from those failures and what they're recommending. And this last point is just pending legislation right now that's happening, where they're really trying to tie actual quality care metrics with with resources, so that those nursing homes that are having staffing violations and infection control violations will be reprimanded or given resources. And it's not just based off how many beds you have, you get this much money, but much more linked to quality care. So I've gone a little over my time, my apologies, but with that, I'd love to transfer over to my friend and colleague, Shefali.
Thank you so much, Tara. It's been a pleasure working with you, and it's been so interesting to see how our two areas of law are intersecting, especially in this moment. And that's actually where I want to start, with how it is that Tara and I came together to work on these issues, and it had to do with the clients we're seeing at the clinic right now. Female, immigrant, low-wage workers who work in nursing homes. And I'm going to tell you the story of one of them, Salma, which is not her real name, because she's emblematic of all of the other workers we're seeing. So Salma works in multiple nursing homes. She works 10 to 12 hours per day, most of the time 7 days per week. She's paid minimum wage, which in Arizona is $12 an hour. She is not given hazard pay, even though she's considered an essential frontline worker. And she came to the clinic because she wasn't getting paid overtime, which she's entitled to under federal law. But as we started talking to her, we realized there was something else going on. Just as the pandemic was hitting, she asked her employer for paid sick leave because her son was ill. And her employer refused to give that to her, even though she was also entitled to that under Arizona's earned paid sick time law that's been in effect since 2017. When Salma asserted her rights a little bit more strongly, her employer retaliated. She threatened to call ICE, and Salma said, "I'm documented." Then the employer threatened to call the IRS because the employer had been paying Salma off the books and therefore hadn't been paying payroll taxes. So Salma did what all of our clients do in that situation. She backed way off, and she didn't take the leave because she couldn't afford to be out of work without getting paid for it. And what this means is if Salma had been exposed to COVID, or if she had even been experiencing symptoms, she was going to remain at work among the most vulnerable, one of the most vulnerable populations in America. And the other issue here is that these workers don't have healthcare insurance through their employers, and they don't have other access to healthcare. So it's unlikely that they're going to go and get tested. And so we're seeing Salma's story writ large on the national stage right now. Just a few days ago, on July 5th, the New York Times released the largest set of data we have to date on how many people are getting infected, how many are dying, and who those people are. And this is what those figures show. And this is taken from parts of the country that are, so that it's representative. It's taken from a large enough swath of the nation. So what we're seeing is that Black and Latinx individuals are 3 times as likely to be infected with COVID and twice as likely to die from it. We knew some of those mortality rates earlier, and what experts were saying at the time was, well, this is because people of color tend to have higher rates of comorbidities. In other words, they have underlying conditions that lead to worse results with COVID. But this new data is actually changing that narrative. And now what experts are saying, looking at the infection rate, which is so high, they're saying, no, this is really about the exposures that Black and Latinx individuals are having, primarily because of the work they do, right? So they are essential frontline workers, they can't telework, and they're the ones who are getting exposed to COVID at much higher rates. I put this quote here that's from the New York Times article from a young immigrant mother. She says, we have to pay our rent, we have to pay our utilities, we just have to keep working, which is what Salma told us and all of our other clients are telling us. Now that reality is colliding with nursing homes, where 1/3 of immigrants work in that industry. I'm sorry, 1/3 of the people in that industry are immigrant workers. And as Ellie mentioned earlier, 43% of all COVID deaths in the United States are being linked to nursing homes. So what COVID has done is shine this spotlight on what we need to be looking at and where the gaps are. And I'm gonna look at 2 areas of law. One is workplace health and safety, the other is paid sick leave. So on workplace health and safety, what's going on right now is that the federal agency in charge of these rules, OSHA, which is under the Federal Department of Labor, has still not to this day promulgated COVID-19 specific standards for what employers and workplaces need to look like in order to be safe for both workers and the public. And in fact, as of May, and so that's on kind of the law side, but the enforcement side is also lacking. So as of May, OSHA had only issued a single citation despite receiving thousands of complaints from workers. And interestingly enough, that citation was to a nursing home where a worker had been infected at work and then later on had been hospitalized for COVID. There are state OSHA agencies, 18 of which have standards that are higher than the federal standard, and some have more specific COVID-specific standards, but those standards vary, and the enforcement at the state level is often even less than it is at the federal level, mostly because of resources. I do want to mention that OSHA has promulgated guidelines, and some of them are industry specific, which is helpful, but the website specifically says that they're just tips for employers and they're not legally binding. So employers are really left in this realm where they don't know what exactly they need to be doing in order to protect safety. So the other area I want to talk about briefly is paid sick leave. Because of COVID, for the first time ever, we had federal legislation that mandated paid sick leave, but there were big holes in that law, and there continue to be holes in that law. So first of all, there are exemptions for healthcare providers, and employers get to decide who's exempt and who's not. So this law likely wouldn't have helped Salma because her employer could have decided that she was exempt and therefore couldn't receive that leave. It also exempts large employers of 500 and more workers, and it also exempts small businesses of 50 and fewer employees. Also, this law has weak retaliation protection when compared to other similar employment and labor laws. And that's, if you'll remember, exactly what Salma experienced was retaliation when she asked for leave. States have earned paid sick time laws too, and Arizona is a good example. So in Arizona, for every 30 hours you work, you earn 1 hour of what's called earned paid sick time, and that goes up to a certain number depending, it gets capped depending on how many employees are at your place of work. These laws tend to have much more robust retaliation protections, and that is true in Arizona. However, there isn't the enforcement to go with it. So in other words, even though Salma was protected from that retaliation that happened to her, there was nobody saying to her employer, hey, you can't do that or else. And part of that is because enforcement has been so centralized, both on the federal level and also at the state level. So all of that is very dire. But there are things that we can learn from what's happened. And I've outlined 3 areas that we can target to ensure that we don't have this happening going forward. So the first is laws and regulations, right? We can fill those gaps that I just identified. And there are model policies and legislation that's been introduced that attempt to do just that. And we can start with having a uniform COVID-19 standard. And I want to emphasize that this is not just good for workers or the public, like residents of nursing homes, but it's also good for employers. I was on a webinar yesterday, and industry spokespeople were saying that employers want to have a standard, both so that they can safeguard health and safety, but also so that they know where their liability lies. In other words, they want to have liability protection, and a standard would be one way of doing that. Retaliation and enforcement, I've talked about already. We need to make sure we have robust retaliation measures in any of these laws, but also we need to see that we increase enforcement. And part of that is resource and funding. Part of it might be to decentralize that enforcement. So in other words, we could ask city attorney offices, county attorney offices to be more engaged in the enforcement piece, because they're closer to local businesses, they're closer to the community. And this leads to this third piece, education and outreach, which we don't hear about a whole lot, but I think about it because it's a lot of what we do at the clinic. And we need it for workers so that they can understand what their rights are and also know how to bring those issues to their employers. For example, if they bring them in a group, they're much more protected under other employment laws. But also for employers, because the reality is many employers don't have the resources to hire a lawyer to walk them through what they should and shouldn't be doing. And so helping them with this piece might go further in creating a dialogue between employers and workers to ensure that everybody is safe. So I want to thank you all so much for being here today. And I want to thank Ellie for moderating, and certainly thank Megan and Karina for putting this great event together. Thank you.
Well, let me jump in here. We already have a number of questions. And I guess the first one I want to address to you, Shafali. One of our viewers asks, why is race related to COVID morbidities? Could it just be population density, difficulty of social distancing? Or, you know, is it because of different kinds of factors in the workplace and so on?
So that's a great question. And I don't know if we'll have definitive answers to that for some time to come. But here's what the experts are saying right now, especially after looking at this most recent data set that's been provided. And I wanted to mention that data set, it comes from the CDC. So it's the government, and they've been collecting this data. It's based on 640,000 individuals nationwide and almost 1,000 counties. So that's why I say that this data is really representative of the entire country. So you said that is it because of population density? Well, when in the beginning, people thought that it was happening. We were seeing it in the big cities. We were seeing these discrepancies in places like New York. But this data shows that it's actually everywhere, including in more rural areas. And so now what the thinking is it's the reason why people of color are more disproportionately being affected and exposed is because of two things, actually. The jobs that they have, so I talked a little bit about that, also about the housing situations that they're in. So they are more likely to be in more crowded situations in terms of housing. And also in the Latinx population in particular, you have lots of family members, not just the single family unit, but maybe extended family living together. So it's a combination. The thinking right now is that it's a combination of those factors.
Tara, let me ask you another question that we've gotten in the Q&A. What do you think of isolation of the sick from the healthy population in nursing homes? And also, there have been some places that have had quarantining of the elderly sick together. And do you think that's a good idea?
I think it's a great question. I think that we need some way to contain the virus, so because it can spread so easily. Like now some claims it can be spread in the air as almost like an aerosol. So when something can be spread that easily, I think it's important that to separate out the healthier individuals and those who do not have it, especially when healthier just means you don't have corona, but you still could have a number of other underlying health conditions that can make you very vulnerable to what could happen if you develop it. So I think that this is coming out in different ways, and overall, there needs to be some way where you can isolate out the those who have. I think it's good to not use the terms healthy and sick. I think maybe those that have the coronavirus from those who do not, to minimize exposure. And so you're seeing this play out now where an article ran yesterday at NPR that our Director of Development shared with us, where there's groups, this one was called the Institutional Rescue and Recovery Coalition, are actually going into nursing homes and trying to take out who they think hasn't been exposed from who has. So you're seeing movements go in both directions, where should we keep the sick with the sick, and or how to keep the healthy with the healthy. And and different countries are handling it different ways, but there seems to be, you don't want to mix the two, and how to do that without infringing too much on individual rights, and communications with the family also still needs to be paramount, and that seems to be continually a struggle during the pandemic. That was the question.
Well, here's a question maybe for both of you. Are there any states or jurisdictions that have done a good job of providing affirmative protection and relief, such as paid leave and anti-retaliation measures for the low-wage frontline healthcare workers? And if so, what differentiates these jurisdictions from others who haven't protected the workers and the patients?
So I can take that initially, and then Tara might have some things she wants to add too to that. So California is a place that already had, and I think you're seeing this very much, places that already had both robust leave laws and also enforcement of those laws have been able to step in much more quickly and do this with respect to all frontline workers, but also workers in nursing homes. So California has implemented hazard pay for certain types of workers that are considered essential frontline workers. And then they have their paid sick leave law that they've had for a long time, but they also have a state level labor agency that is much more proactive, from what I understand, in terms of making sure that employers are both providing that leave when workers are asking for it, but also that if employers are retaliating and if people are asking for that leave, then there's a graded penalties. And I want to point out that in Arizona, we have that written into our law. Our earned paid sick time law is actually quite robust, and many states share a very similar law, but it's the enforcement that's really making the difference from what I'm seeing right now.
I may add an international perspective that could be helpful regarding low-wage workers in nursing homes. So as you said at the very beginning, Ellie, that we've seen about 40% of the deaths related to coronavirus being linked to nursing homes or long-term care facilities. So that percentage is double in Canada. Over 80% of the deaths are linked to nursing homes, long-term care. And that's for different reasons. It's partially because they have the pandemic more under control in Canada. So the deaths that they're seeing are largely happening because of those institutions. But they pinpoint the same issues that we identified in this talk, where there's lack of paid sick leave, pressure to work even when you're symptomatic, and even lack of testing to know if you could have the virus. And I think it's helpful to look at the success that Hong Kong is happening, and the failures that's happening in Canada and the UK and other countries, to get an international sense of just how the world is treating an vulnerable older population during a pandemic.
It's so crazy in a way as you're talking about this, because I think we have such a clear identifiable front line of the virus in nursing homes. And I'm wondering, should we be putting more resources into care in this environment? And what recommendations would you each have for the kinds of resources and the place where you would deploy those to have most effect in terms of cutting the disease rates and death rates with both of these communities?
Yeah, I'd like to start. Just Molly, you can add, because I think this is happening right now, where it's almost like panic funding dispensing, where the HHS is like, well, we're going to give, I forgot what the exact figure is. I have it written down here, but 4.9 billion out to nursing homes based on the number of beds. So if you have basically $2,500 per bed, 50,000 per facility, and that's just based off how many beds you have per facility. It's not based off whether you have adequate staffing levels, whether you've had infection control violations, whether you have proper reporting procedures, just based off beds. So first off, to get a better sense of how to actually improve quality care, help award institutions that are trying to meet those metrics, which are costly, and either penalize or help reinforce where we could bring up the other institutions, and just simply not taking that time to actually look at what's causing the virus to spread is this lack of infection control, the lack of awarding paid sick leave. It would be much more proactive than just sending money off, thinking just money is going to answer the problem. And that's why I'm so optimistic about that recent legislation I noted in my PowerPoint, because even if that fails, at least we're finally having the conversation. Okay, maybe Shefali wants to add.
And I think what I have to say is very similar in the employment realm, which is, we did see, our government has already spent billions of dollars on the CARES Act and the FFCRA, which is the Emergency Paid Sick Leave. But there's nothing, employers aren't, in addition to that, employers aren't getting guidance about what workplace health and safety measures they need to be taking. So they're getting this influx of dollars, but they're not getting guidance, and they're not getting the kind of, I think the kind of really hands-on, and it would require more resources at the Department of Labor level, but also perhaps at the state level, to help employers understand what they need to be doing so that they're not seeing this high level of attrition with workers getting sick, in the nursing home context, making the public sick. And I also want to add one other thing, and this is again about more dollars, but what Germany is doing seems to be working really well, and some other countries, European countries too, is that the government is providing much more kind of broader unemployment insurance benefits for people, and some states we're seeing are providing more workers' compensation, and they're saying, we're just going to assume that if you get sick on the job and you have COVID, that it's something that you can be funded through workers' compensation for. So this gives people an ability to step back and say, okay, I'm going to be okay economically if I do have to take time off of work, if I do have to be gone for an extended period of time. And this is very important for immigrant workers. Right now, the way the CARES Act has been styled, unemployment insurance is not available to many immigrant workers in our economy, and these workers are at nursing homes as well.
I have a question, Shefali, coming back to you about how much of an immediate issue is communicating the rights and the access to legal help like your clinic. It seems like there may be some help and opportunities for workers if they can get some help in the short term, while they're trying to address the legislative and regulatory issues in the long term.
Right. I mean, if I'm understanding the question correctly, that's partly what I just mentioned about if we can increase the pool of people who are eligible for unemployment insurance benefits and increase those amounts, right? The $600 additional amount that's set to expire the end of this month, if that's not continued, then that's not going to be that helpful, even if you expand the number of people who have it. And I do want to mention that there's also a side note about the economy here. There was a great op-ed written in the also in the New York Times a few days ago, showing, you know, really in black and white numbers, that if we continue having this level of unemployment insurance for folks, it's actually going to be a benefit to our economy. And again, this is looking at what's happening in many European countries where that has been true. So it's helping everybody, not just the workers, but also the workers who are involved. Does that answer that question?
Yeah, I think so. And I think what you're talking about, which makes sense, is you're really trying to help. And I think this is what our questioner was asking too, pardon my bad paraphrasing. And that is, you know, you've got to help people both in the long term to get the kinds of structural change that are going to work, and in the short term through the kind of work that you and your students are doing in the clinic. There are some rules, there are some regulations, and to really help people get the information and assistance they need to at least make sure that we're living up to the more limited regulations that we do have in place right now.
Yes, and I want to add one thing, since you clarified that, thanks, Ellie, which is that we are the only workers' rights clinic in the entire state of Arizona. So we can do a lot, but what we can do is limited, obviously, by the number of students we have in our clinic. And our minimum wage and earned paid sick time law actually has written into it an education and outreach component for workers and for employers. But again, the state agency that's in charge has one investigator for all of Tucson, for example. So, you know, you can't take that limited amount of resources and expect any kind of short-term assistance like the person asking the question is talking about. We really need to put so much more, and you know, there's so many creative ways we could be doing that.
Why don't you say a little more about your creative ways to be doing that? That's so provocative to talk about.
Well, I think students are such a wonderful vehicle for this work. I mean, first of all the students that I have come into contact with want to be more engaged with the communities that live around the university, right? And so, you know, why can't we have programs where students we have 3 fantastic, amazing universities in this state. Why can't we have some sort of mobilization where we work in tandem with the Arizona Industrial Commission, that's our state labor agency, to provide this type of outreach and education in communities like low-wage worker communities, immigrant communities that otherwise wouldn't receive this. And I think that we could very much do that on the employer side too.
It just sounds like a great idea, and we need to get you more resources to make that happen. I personally promise to contribute some resources to that effort. It's just great work that you're doing. Another question, which authority, federal or state, Tara, do you think is likely to provide effective regulation of nursing homes? And do we have a situation where the federal government is saying that this is a state responsibility and states are saying this is a federal responsibility, so we're just pointing fingers?
Yeah, well, yes would be one way to start to answer the question, I suppose. The federal regulatory agency that oversees nursing homes is the Centers for Medicare and Medicaid Services, and they work in tandem with the states, and often the Director of Health and Human Services for each state, who then sends out inspection agents who go and monitor the nursing homes, and there's a conditions of participation that nursing homes have to comply with in order to receive Medicare, Medicaid funding, which we all know is how critical to their infrastructure. This is kind of just a side note, maybe just to mention, because I haven't said it so far, but one interesting issue that nursing homes are battling with is they actually receive more money for accepting COVID-19 positive patients than they do for Medicaid patients in their nursing facilities. So if you're looking at your bottom line and how to balance a lot of the shortfall that you've been facing, you may be more eager to accept COVID-19 positive patients and hope for the best in terms of trying to control the virus. So that could, so just how we've been incentivizing facilities to take on patients over Medicaid only paying patients is something to consider that I had not yet had a chance to mention. Gosh, there's so many ways to go with what you said, but I think that I'll go back to the issue with states blaming, maybe they're blaming the facilities, blaming the states, blaming the federal government in terms of whose fault it is that these deaths are skyrocketing, and that's happening in every regard with our pandemic around the country. I think that what we've also seen very recently come into the news again is just a shortage of personal protection equipment, and these just horrendous stories of essential workers wearing garbage bags and swimming goggles and other devices to help protect them from the spread. And then some of these fines that you get are ridiculous. So the facility I mentioned in New Jersey that had the makeshift morgue where they were hiding 17 bodies, they were fined. They weren't shut down. They were fined $220,000. They hid human bodies, and they were fined $220,000. So there's a huge disconnect between what we're actually inspecting and reporting and expecting of these facilities, what we're providing, and just at every single level, there seems to be lots of problems and lots of work that needs to happen. And these are things that there were horrendous things that happened pre-pandemic, and it's just because of the scale, we're really seeing it come to the surface.
Well, I'm told we are running out of time. Let me ask you one more question and then give you both an opportunity to wrap up. Shefali, we had a couple of questions. One about, do you expect that opening schools will increase the disproportionate impact on Black and Latinx workers since they may be less able to choose whether to send children to school based on precarious employment and alternatives? And also, what do we see in terms of coronavirus effects and for workers who are American Indian and Alaska Natives?
Those are both great questions. I'll take the first one first. So I've read very conflicting things, and this is not my area of expertise on whether or not children can transmit or the rates at which children transmit COVID. When I was first listening to that question, I thought it was going in the direction of essential workers at schools who are from Black and Latinx communities and other communities of color. And I think definitely the answer there is yes, because janitorial staff, cafeteria workers, these again are people who are not going to be teleworking. They're going to be at the physical school facility. And then I think, yes, that exposure certainly can be there. And of course, the other piece of the question is true too, right? Everyone in any industry that's an essential worker, they need that childcare. They can't be doing what we are doing, which isn't easy, but it's doable, right? When our kids are over in the next room and we're doing things on the screen. So yes, I think it will affect communities of color disproportionately if schools reopen. But it will also affect communities of color disproportionately if they don't, right? Because of the need for childcare. So it's a real bind for essential frontline workers. In Arizona in particular, and I don't have these figures at my fingertips, absolutely. I mean, COVID it's more than 3 times the general population that it's affecting Native American communities. And we're seeing that very much right now here in Arizona and in I think a couple of other states, but I think it's more here than anywhere else. And those figures are in that data set that the New York Times released from the CDC, although I didn't have it in my figure. Thank you for asking about that.
And why don't you both just wrap up, tell us a little bit. There's so many valuable insights that you all have shared and so many topics that you've touched on, but maybe just you know, what are a couple of things that you think are the most important recommendations right now in terms of protecting our vulnerable populations related to nursing homes and long-term care?
I think I may have emphasized this already, but I just feel that we're at this tipping point right now where we're seeing half the states pass legislation that's giving immunity to nursing homes so they don't need to take even reasonable minimal precautions in preventing the spread. That's one direction. The other direction is finally linking actual metrics that have been proven to help control the spread. So as you're looking at these two comparisons, to hopefully go with the latter. And because it's not just this pandemic, there's going to be future pandemics. There are infectious disease outbreaks, and to allow increased immunity, to not provide the resources where they're needed, to not try to link together reporting with metrics and resources, you can't get a handle on these things. So that's where I'd like to see really proactive work looking at how vulnerable we are with this intersection, particularly with, you know, the work that Shefali is focusing on with immigrant low-wage workers and a very vulnerable population. And one of the biggest issues is paid sick leave without retaliation is where we're really heading.
Terrific. And in Arizona, we have a little help on the immunity front because we have some great state constitutional provisions that may prohibit our government from giving immunity to different kinds of organizations. Shefali.
And I would just like to build on what Tara said. So we actually already have some immunity legislation on the federal level for workplaces, but we didn't marry that with the COVID standards. So that's very problematic, right? We need to incentivize for employers to actually put the things in place that are going to make their workplaces more safe. So I would say if we're going to even look at any type of liability shield for employers, we have to make sure we're also telling those employers the things they need to be doing in order to qualify for that immunity. And on the and then of course on the paid sick leave side of things, we have to incentivize for both employers and workers to take that leave that they are already entitled to under our federal law and under many state laws. And that, I think, does have something to do with an infusion of more resources.
Well, thank you both so much. We could go on for hours, I know, and probably will after this show. But for those of you who are joining us today, let me remind you that this is just the first in our Thursday LawCats Live series. Next week, Dean Tony Massaro, Professor Justin Pideaux, and Associate Dean Teresa Miguel Stearns will talk about how our constitutional rights might inform the planning of our new safe returns. And so look at the Arizona website for the LawCats calendar, and also you can Google the series on the website and look at the calendar. And I'll look forward to hearing so much more over the next few weeks as we have more conversations on Thursday. Thank you again so much.
Thank you. Thank you for moderating.